I'm really delighted to be here with you in this really interesting topic about atrial fib and the possibilities that we have in treating our patients. And in fact, as you know, the problem of atrial fib is not really the rhythm disturbance. It's related to the embolic events. And when we realize where is the real problem of the embolic events, I think that you will all agree that the left atrial appendage really is a key player in this movie. And in fact, in patients with atrial fibrillation, over 90% of the stroke is caused by the clots that are allocated in the left atrial appendage. And as you have seen this morning, the recent update guidelines in atrial fib recognize for the first time the possibility of the left atrial appendage closure as a potential alternative. No doubt that there still is to be, no doubt that we need more trials, and from the guidelines perspective, I think that this will change, but we need to wait to more solid data and more trials. There are different ways to occlude the left atrial appendage, and we have seen different devices this morning. The common path in all these procedures is that imaging really plays a key role. And if I need to define how is the left atrial appendage, I will say that left atrial appendage is no doubt treacherous, and it's treacherous because it's a higher dilated LAA, it implies a higher embolic event, but also is hospitable. And we know that most of the clots that are inside the heart are inside the left atrial appendage, as we can see here in this slide. It's not the same, the rate of thrombi inside the left atrial appendage is not the same in valvular or non-valvular atrial fib, but still the numbers are quite high in both. So it has been described up to 90% of thrombi in non-valvular AFib inside the LAA, but more than 50% in patients with valvular atrial fibrillation. I will also say that the left atrial appendage is lazy. And I will address this issue in the last part of my talk, but it's not only about morphology, it's not only about size. Well, size matters, but also function is really important. And there has been described different types of functionality in terms of flow coming inside and outside the left atrial appendage that can be easily analyzed with Doppler, and there is a correlation between the Doppler flow and the different types. Is this really related to embolic events? It's still controversial, but what is clear is that we can assess the function of the left atrial appendage with echocardiography. And finally, I think that left atrial appendage is also slippery. It's not easy to assess. It has been a great, excellent talk previously by José Ángel Cabrera, but you have seen that the morphology of the left atrial appendage is not unique. And I think that it's not uniform. And I think that even we can say that there are many morphologies as patients, but what is clear is that usually it's not only a single lobe, usually we have multi-lobes in more than 80% of the population. This is the anatomical specimen of a left atrial appendage. We have the crista, we have the relations with the left upper pulmonary veins, we have also the relation with the circumflex artery, and this can be easily seen and analyzed with echocardiography. Same anatomy can be assessed in detail with echo. So the beauty of imaging is that we don't need to imagine too much. I think that it's clear that the echocardiography, especially the transesophageal approach, offers us a complete view of the morphology of the left atrial appendage and also its relationship with the surrounding structures. If this is true for 2D transesophageal is mainly true for 3D echo. I think that no doubt I will show you later some examples. 3D echocardiography offers a complete view of the surrounding structures and what happens with the LAA. And in fact, one of the things that I am sure that in the near future will be addressed, and the same as TAVI, that usually we are taking decisions with 2D information, taking decisions in 2D for a 3D structure. So maybe we will need to shift in terms of diameters, moving to terms of volumes or areas in order to select and guide our procedures. But the world in LAA closure is not ideal. And it's not ideal because the left atrial appendage is not uniform in anatomy. As I said, it's a complex morphology most of the times. We can clearly identify this complex morphology either by echo, by CT, MR, or angio. But what is clear is that in complex morphology, left atrial appendage, we will need to be sure that we are solving all the problem. This means that we cover all the lobes, that we cover all the potential source of embolism. And another added problem is that quantifying the neck or the depth of the left atrial appendage is sometimes not easy. It's not easy because, as I said previously, a 2D measurement will not always inform us about a 3D structure that is the left atrial appendage. And this is why we need to be really sure what are we doing, what are we watching at, and also what is the potential landing zone and what is the really orifice, the area and the depth of the left atrial appendage. What are the potential advantages of imaging? In fact, the first question is, who are the real patients at risk? Not all the patients are the same, and I do believe that echo and imaging really answer these questions. First thing is assessing risk. And assessing risk with echo, we have many different factors that really implies higher risk of embolism. And then we have the size of left atrium and also left ventricle, the LV function, and absolutely new, we can talk about the left atrial function. And this is also related with embolism. No doubt that the presence of thrombi is a marker of increased risk, so as the presence of atheroma plaques. So in fact, let me enter in pure echocardiography, then I will move to MR, and just one slide about CT. Role of echo implies morphology and function. Let me start with morphology. Well, this is a comparison with an echo study, and the first thing that we need to do with echo is analyzing the morphology of the left atrial appendage, and as you can see here, most of the cases we have more than one lobe. So we need to really give this information to the invasive cardiologist. But not only that, we need to absolutely be sure that there is no thrombi, or there is a thrombi inside the appendage. And in fact, sometimes it's not easy, and it's not easy because we have the pectoneal muscle inside that sometimes it's not easy to differentiate with the thrombus. Transesophageal echo is a must to rule out this diagnosis, and the sensitivity with TE, with transesophageal, is really 95, is extremely high, with an specificity that has been reported in some series about 100%. Well, is there any role for 3D? Well, 3D, in my view, is not a must. We can do it with 2D, but it's better. How you like to see something that had happened with a picture or with a video, with a movie. So video gives you more information. 3D offers you more information related to the left atrial appendage, the morphology, the neck, the depth, and also the surrounding information. And as you can see here in this loop, is you can get, especially with the biplane landmarks that you have with transesophageal 2D, all the information of the left atrial appendage, but in two dimensions. With the 3D, you can crop the image, you can really get and go deep inside the left atrial appendage and analyze what's going on with this. Well, in most cases, the invasive cardiology, they really need to compare and they want to see in the angio what we said with the echo, and it's clear that the orientation with the angio is quite important for the invasive cardiology. But this really correlates with what we can see with echocardiography. And in fact, the size of the neck and the depth of the left atrial appendage is crucial in order to place the device in a stable position and to avoid possible complications. Not going to enter too much in specific details, but just to share with you that the distance here, the distance with the width of the orifice, the depth are crucial in order to select the proper size of the device. How to quantify this? I think that no doubt echo is the method of choice, and the beauty of echo is that even you can check that inside the cath lab while or during the procedure. There is again just to show you that even with 3D echo you can clearly identify the device inside the left atrial appendage. You can see the perfect position, and this information with 3D is more complete than the one that can be offered even with multiplane 2D transesophageal echo. Well, echo also is quite relevant to detect complications. And well, this is a nice image of a patient with 2D, a lot of spontaneous echo contrast, smoke inside the left atrium, and a thrombi inside the left atrial appendage that can be easily seen, the area, the attachment point in the 3D echo. Well, let me show you an example of a patient that everything was properly assessed with 2D echo, but again, as I said, it is two-dimensional. It's a nice left atrial appendage with the proper depth. The device was placed inside the left atrial appendage, and everything seems was correct. Diameter was measured, but a few minutes afterwards, we can see the dramatic embolism, or the device was outside the left atrial appendage. No problems later with the patient because the invasive cardiologist was able to extract the occluder. But again, this is a good example that you really need to have the proper measurement, the true and volume of the appendage, and these things seldom happens but may happen, so you need to be prepared. Again, 3D may help in order to analyze exactly the area and where the device must be properly placed. And the other new aspect that I would like to share with you very briefly is that imaging also, and especially echo, provides a function, the information of the function of left atrial appendage. And this may be quite relevant in order to see what is the real risk or the added risk of a patient of suffering embolism. And this is important because this may help in selecting patients that are more suitable for one procedure or just for oral anticoagulation. Well, the new concept of stenting, we know stenting in the left ventricle. We know this concept of stenting in the setting of coronary artery disease. But now it's getting more and more popular, stenting of the left atrial appendage. And what this means is that the flow in the inside the left atrial appendage or the left atrial appendage is not really doing a proper job in terms of emptying the blood that is inside. And it's really defined by velocities inside the appendage that are quite lower, and you can analyze that with the new Doppler techniques. Well, we know that the presence of stenting in the left atrial appendage, those patients are more prone to have recurrent atrial fibrillation, seems higher risk. And what is also very important to know is that the left atrial appendage stenting is not really related with the duration of the atrial fib, but seems is related, is more related, as you can see in this nice paper published in the journal American Society of Echocardiography. You can see that it's really related to the velocities that can be analyzed by Doppler. In addition, we have now tissue Doppler. Tissue Doppler allows to quantify the velocity and the direction of tissue motion. And it's quite, in this paper, is really nice to see that the new index of the electromechanical conduction time that really reflects the conduction inside the atrium, we can analyze that with the tissue Doppler. We analyze the velocities of the ventricle in the annulus, in the septum or the lateral annulus, and we analyze the systolic movement, this is the early diastolic, and the late diastolic motion in terms of velocity. And in this paper, you can see that the prolonged electromechanical activation delayed implies recurrent atrial flip. And in fact, in the lateral aspect, it was unique, an independent predictor, really independent predictor at 6 months in order for recurrence, and also a nice sensitivity and a specificity of this new index. So, as you can see here, this is the patients that with recurrent atrial flip, the electromechanical index assessed by tissue Doppler implies more or higher risk in these patients when it's prolonged. In addition, this is related, as expected, with the index, the left atrial index. And finally, we have also some data related to spontaneous echo contrast. So spontaneous echo contrast, this is a smoke that we can see in the left atrium, has been related with the potential increase in embolism. This is still a controversial issue, but in this paper you can see that transesophageal echo, the presence of thrombi or spontaneous echo contrast was really a marker of risk in our patients in order to estimate the potential risk of a stroke, and this was assessed mainly with the transesophageal approach. The final part of my talk, just a couple of words related to MR. What is the beauty of magnetic resonance? This is a paper published in JACC, and you can see that magnetic resonance offers us a great tool to assess morphology. So echo was morphology and function. MR is mainly focused in a deep way to assess the morphology of the left atrial appendage. And not all the atrial appendage are equal, are the same, are not equal in terms of morphology and are not equals in terms of risk. We have the windsock type. This is a dominant lobe. We have the chicken wing type. Remember, this chicken wing type is really a sharp bend in the dominant lobe. And we have also the broccoli type or some complex types like the cactus or the cauliflower. All these morphological or different morphological types are quite relevant because we know that the non-chicken wing type implies more presence of strokes. So a specific morphology implies we should look more carefully to these patients. What about CT? Less information, but the anatomical aspect of the evaluation of the morphology of CT is really also very good. The only thing is that we expose our patients to radiation and we don't assess also function with CT. So dear colleagues, in conclusion, I think that is no doubt that imaging helps a lot, and it helps a lot in detecting risk. In detecting risk by twofold. First, morphological, anatomical information for potential candidates and markers of risk, but also functional information that provides added risk. No doubt that echo is a great tool because it not only detects potential candidates for these new devices, but also monitor the procedure inside the cath lab, detects complications. How to do that? I think 2D echo transesophageal is a must, no doubt. 3D, very helpful. If you don't have 3D, you can do it with 2D. This is for sure. Without transesophageal, I will not recommend to do these procedures, and the final table will show you that functional or structural heart disease, transesophageal echo offers the same information as MR, more than CT. Then if you move to what happens with the pulmonary veins, guiding therapy, intra-procedure, no doubt that echo is a great tool. And if we go on to assess complications, again, transesophageal is a great tool. And also you need to assess what terms of the cost, rotation, availability, that is no doubt that echo, again, wins the battle. Thank you very much.